respected dignitaries of IMA Nashik, IMA members, Dr. Abhijit, Dr. Smitha, distinguished audience, thank you very much for asking me to speak a few words on premature ejaculation. Sex is a condition of mind where mind is out of condition. If you analyze the historical perspectives, you can really appreciate the paradigm shift with reference to the conceptual issues and also the treatment modalities of various disorders and dysfunctions. These functions are more commonly perceived with the male libido when compared to the female libido because there is something called performance anxiety that is disturbing the male libido. As already mentioned by the previous speakers, I think what is happening in the penis is also happening in the clitoris, and the female arousal is modulated by vasoactive intestinal polypeptide, and subsequently after the arousal in the initial phase, it is probably taken up by the central dopaminergic mesolimbic mechanisms. Unfortunately or fortunately, I think the male arousal is probably the sexual response is linear model, and the female sexual response is a circular model. And probably here, there is an urgent necessity of producing a new process called tumescence or erection at the time of arousal. And the male has to maintain the erection during the penetration. Not only that, even after intermission, he has to maintain the erection. And not only that, even up to the time of producing orgasm simultaneously. So this is causing the performance anxiety, and that could be the reason for most of their sexual dysfunctions, such as erectile dysfunction and premature ejaculation. Strictly speaking, I think we try to really understand premature ejaculation as a different concept with reference to erectile dysfunction. But there is one type of premature ejaculation that is part and parcel of erectile dysfunction. That is ejaculatio antepartus. Even before intramission, the person is really going for ejaculation. So erection is not achieved or partially achieved, and probably this fellow is going for intumescence. Whatever it is, in the legal paradigm, this is construed under the concept of impotence. Leo Tolstoy once said, men can tolerate, accept any kind of a defeat or failure in the battlefield, but he cannot accept the tragedy that is happening in the bedside. Why I'm not able to, one minute. Premature ejaculation is underreported because of the fear of being embarrassed by the peer group of friends or the relatives. It is undertreated. Why it is undertreated? To know about the sexual history, one has to spend some time, and to formulate the therapeutic regimen, one must be familiar with the psychological, non-pharmacological management, as well as he must be very familiar with pharmacotherapy also. Men with the PME, they present with the psychological distress, and this could be the reason for avoiding the spouse physically as well as emotionally. And you know what happens? They become the victim of quackery. They subject themselves for false medical advertisements and become the victim for unproven medical management. What is PME? It is an inability to control or delay the ejaculation. We all could have traveled by train. Imagine a situation in a particular junction, railway junction. If you arrive before the arrival of the train, I think there will be a visual display that a particular compartment, AC first class, or second AC, or third AC, or unreserved, reserved compartments probably would be parked here. Imagine the engine driver or the train pilot is just parking just 100 meters before the parking zone. There may be a disarray. Something similar to that. What is happening in this individual, the male, he is probably ejaculating even before the completion or the expected level of pleasure. And that is considered as premature ejaculation. There are so many definitions available, but the International Society of Sexual Medicine, ISSM, proposed inclusion of an objective quantifiable time to ejaculation, ILT, intravaginal ejaculation latency time. That's the time between intromission and ejaculation. If you analyze the historical perspectives, one can really appreciate the paradigm shift. In the early period between 1887 and 1917, science was very primitive. It was 1887 Grass first presented the case of premature ejaculation. And it was 1901 von Krafft-Ebing. If I'm correct, I'm subjected to correction. He is the person who proposed he really coined the word perversion. He presented the second case. The period between 1970 and 1950 was the hegemonious period for the psychoanalysis. And everything was construed, understood, deciphered, analyzed with the psychoanalytic principle. So in 1917, Carl Abraham believed it as a neurosis and he attributed to unconscious conflicts. But in 1943, Bernard Shapiro believed it as psychosomatic and he typified it into two different categories. One is the primary, which is going to be lifelong, and second is a secondary, which is going to be an acquired one after having a normal sexual experience. The individual, probably due to some organic or psychological factors, could have experienced this particular defect. 1950 to 1990,
Motion.
the behaviorists, they emphasize that all sexual problems could be addressed, elevated by behavioral techniques. William Masters and Virginia Johnson, they advocated stop-start technique, cues technique, and sensate focus. Only with the advent of SSRI in the 1990s, selective serotonin reuptake inhibitors like fluoxetine, citalopram, sertraline, paroxetine, and the short-acting SSRI like the depoxetine, and the topical anesthetics, aerosol sprays, I think that was another shift to pharmacotherapeutic measures. This is the neuroanatomy of ejaculation. I'll probably explain to the next one for clarity. Ultimately, it is a touch that is really, making the person to go for excitement from arousal. The sensory perception at the level of the prepuce of the penis is probably related to potential nerve, and subsequently it is related to hypothalamic plexus that is modulated by T10 and L2 sympathetic ganglia. There are three areas of ejaculation, two in hypothalamus and one in midbrain. The medial preoptic area and the paraventricular nucleus in the hypothalamus and periaqueductal gray in the midbrain. The efferent nerve, probably acting on the seminal vesicles of prostate and bulbourethral gland to have increased volume of seminal fluid, and it's also having an impact on the vas deferens. That is probably sending the sperm to the posterior urethra, and this is parallel with the stage of emission. And subsequently, I think the efferent fibers probably they are responsible for rhythmic contractions of ischiocavernosus and bulbocavernosus and pelvic floor muscles. And this is the responsible factor for the next level, that is ejaculation, and subsequently it is paving way for orgasm. So the medial preoptic area of rostral thalamus and nucleus paragigantocellular in the ventral medulla, these are the important area, and electrical stimulation of medial preoptic area promotes ejaculation. The mechanism of ejaculation consists of two phases. One is an emission phase, which is mediated by thoracolumbar sympathetic system, and ejaculatory inevitability parallels this phase. I think the depoxetine probably that is reversing the situation. And this is a phase where I think probably behavioral techniques like cues technique would be really, useful for going for retumescence. And the second phase is the expulsion phase that is modulated by somatic nervous system, and orgasm is associated with timing of this phase. PET studies, we have a strongest activation of, we have an evidence that there is a strongest activation in the mesodiencephalic region, which comprises of ventral tegmental area, the reward area, and the lateral and central tegmental field. Amygdala is concerned with anxiety. When there is a lessened activity of amygdala, the brain loses fear and anxiety during arousal and ejaculation. Unless until the individual is detached from anxiety, I don't think you can really go for arousal and proceed with excitement. There seems to be hypothalamic involvement seen in animals, but that is not replicated in human beings. What exactly is happening in normal ejaculation? The touch is there, the foreplay is probably there. The person is, the male is going for excitement, sexual arousal, penile tumescence, heightened excitation, and penile erection. This is happening in a gradual way. And the individual is penetrating. And here comes the fourth plateau stage. And subsequently, it is going for ejaculation. And after that, probably detumescence and resolution. What exactly is happening in the premature ejaculation? The excitement, arousal from excitement is rapid. It is not gradual. Probably the sympathetic nervous system is going for a hegemonious level, and anxiety is also killing that individual. And what exactly is happening? There is a kind of a spectating, and that is responsible for short plateau. Shorten the plateau phase that is responsible. It is said that the previous experience, sexual experience, would be really, the experiences that would be occupying the cognitive realm of the individual in the subsequent experiences. So the shortened plateau, the fourth stage, that is responsible for premature ejaculation. What are the key elements of PME? Diminished ILT, intravaginal ejaculation latency time, lack of voluntary control. Third, it should produce dissatisfaction and distress. Normally, the ILT is 7 minutes or more, and there are psychological experiments conducted with a stopwatch with the Dutch people, and probably they seem to have, they have variety of various ILT, longer ILT as well as shorter ILT. In PME, if it is less than 3 minutes, it is generally believed that the individual is probably having premature ejaculation. But DSM-5 is little flexible, and probably it is saying that up to 1 minute. Beyond 1 minute, I think it should not be believed as premature ejaculation. What is the prevalence? 30% of the general population seem to be suffering from this. Gebhard and Johnson reanalyzed the Kinsey data, and they found that 4% of the people, they reported PME within 1 minute of intromission. And if you analyze the US data as well as the European data, generally it ranges from 9 to 30 minutes. What exactly is happening at the molecular receptor level? It is the hyperfunction of 5-HT2C receptor and hyperfunction of 5-HT1A receptor. So any molecule, any substance, any drug that is reversing this level and able to produce hyperfunction of 5-HT2C receptor and hyperfunction of 5-HT1A receptor, I think must be in a position to help the individual. And here comes our depoxygen, short-acting selective serotonin reuptake inhibitor. Hyper-excitability or oversensitivity of the penis, that is preventing the downregulation, sympathetic pathways, and delays ejaculation. In PME, there is a higher level of testosterone, lesser level of acid phosphatase and alpha glucosidase, and the lower serum prolactin and lower ILT. According to ICD-10, that is an inability to control ejaculation sufficiently for both partners to enjoy sexual interaction. That's all. But DSM-5, it differs. Persistent recurrent ejaculation occurring during partnered sexual activity within approximately 1 minute. If it is beyond 1 minute, I think it is not PMA, and this is going to really open a Pandora's box whenever the case is really in the court. And following vaginal penetration and before the individual wishes it. It also includes another factor. Even during non-sexual activity, If the person is going for ejaculation, that should be also construed as PME, but there is no specific duration, whether the individual should have erection or whatever it is, or watching or seeing a movie or whatever it is. That is not properly explained. What are the types of PME? One is the primary and secondary, according to Gospidinoff in 1989. What is the ejaculatio post partus? Here, the individual is probably ejaculating immediately after intromission. There is another category, ejaculatio ante partus. Ejaculation occurs before the penis is introduced into the vagina. Shapiro's classification, type A, that is hypertonic, that is acquired, and type B, sexually hypertonic and hypererotic, and this is going to be lifelong. Waldinger is a person who had done extensive research in the area of premature ejaculation, and he believed that ILT must be the scientific measure of ejaculation time. That's the time between intromission and ejaculation. There are 4 types, according to him. One is a lifelong PE. Second is an acquired one. Third is subjective, and fourth is variable. What is lifelong? The ejaculation probably occurs almost right from the beginning, right from the first sexual experience. With every woman, from the first sexual encounters, 90% I think they ejaculate within 30 to 60 seconds and 10% within 1 to 2 minutes. And 70% I think they continue the status quo, and 30% they go for aggravating their problems. The ability to delay or the control ejaculation at the time of ejaculatory inevitability is diminished or lacking. It is hypertonic and hypererotic. So it's characterized by early erection, erectio precox, early ejaculation, ejaculatio precox, early penile detumescence, detumescentia precox, ejaculation during foreplay, even before penetration, that is ejaculatio ante partus. As soon as the penis touches the vagina, that is ejaculatio intrapartum, drugs may prolong ILT, and the individual has to take the medicine continuously. And as long as he's taking this particular drug, I think ILT may be really lengthened, and the individual may have some benefits. And sometimes it may be little refractory. Acquired PE, the person could have had a normal sexual experience, but due to some organic factors or some psychological factors or relationship problem or marital disharmony, the person is experiencing this problem. It may be acute, sudden, or gradual. And ejaculation is occurring within 3 minutes. The ability or the delay to delay the ejaculation, that is diminished or lacking. Invariably, it is due to a medical cause, urological problem like a prostatitis or thyroid functions or adrenal problem or some other interpersonal issues. I'm telling you, this is hypertonic. So there is no erectio precox. There is no early erection. There is no detumescentia precox. The person will not go for early detumescence. So there is a favorable treatment response once the underlying medical problem is addressed. Coming to subjective PE, here ILT is normal or even longer, and this is due to psychological and relationship problem, but there is a subjective perception of the person. There must be some problem. Consistently, it may be there, or inconsistently, maybe there's something like an obsessive way. The person may be really harboring this particular idea that he is experiencing PME, though everything in reality could be different. And there is a preoccupation with the perceived ejaculation. ILT is normal or longer, and ability to delay or control ejaculation is diminished. Normal tone, erectio precox, early erection, or detumescentio precox, early detumescence may not occur. Treatment is just addressing the cause and by reassurance. Variable PE, this is another one. Here, coincidentally or situationally experienced PE. Normal variation in sexual performance. An individual is experiencing normal sexual relationship with a spouse, legal spouse, probably is going with another woman, or in a very tense situation, is a little bothered about somebody else, worried about legal problems or police problems. At that time, extreme anxiety, you may go for PME. Or I'm seeing a woman, little bit obese or very strong, and that may be really harboring, that may be the reason for harboring unwanted anxiety, and that could lead to premature ejaculation. This is inconsistent and occur irregularly. And sometimes even visiting a commercial sex worker, probably, you may be harboring little doubt about his performance, and he may be indulging as a spectator, watching his own performance as a third person. This is going to be really problematic, and that could be the reason for this variable P. Whereas in a relaxed milieu, he may not have premature ejaculation. Ability to delay ejaculation is diminished or lacking, and there is a short or normal ILT. Again, erectio precox and determinatio precox do not occur. It may be addressed by pharmacotherapy or psychological management. So, how to really approach PME? Focus on ILT. If it is less than 1 minute, it should be primary or lifelong. If it is between 1 and 3 minutes, it should be acquired. Look for any physical problem, organic cause, look for psychological problem, any relationship problem. When there is a normal ILT, look for whether it is a subject perceived problem, a subjective P or variable P. Why I am repeating this? The primary lifelong PME may have a genetic basis, a neurobiological basis. Acquired secondary PME, it may have a hormonal reasons or psychological reasons, and normal variance, variable, and subjective probably misconceptions. And primary PME that is addressed by first line pharmacotherapy, then only psychotherapy. Acquired, treat the cause, medical management, subsequently pharmacotherapy, third is psychotherapy, fourth is education. And variable reassurance, education, behavioral therapy. Whereas subjective premature ejaculation, first line is psychotherapy, reassurance, education. So choosing the treatment modality probably depends on the type of premature ejaculation. There is a genetic polymorphism with the primary PME. 5-HTTLPR polymorphism influence ILT duration. LL genotype ejaculated 100% faster than SS genotype, and CC genotype ejaculated 250% earlier than GG genotype, and 5-HT2 receptor polymorphism, the cis genotype ejaculated 79% faster than monozygotic mutant variety. These are all the rating scales for PME. Premature ejaculation profile, 4 questions. Index of premature ejaculation, 10-item questionnaire. And premature ejaculation diagnostic tool, 5-item tool. But with this, I think one can really can identify whether the person is having PME or not. But this is based on DSM-4 TR criteria. Drugs for PME. Choosing the drug, it really helps the individual. It is a kind of a tightrope walking, because sometimes while going for combination of 2 or 3 drugs, this is going to really have more adverse side effects. Depoxetine, short-acting selective serotonin reuptake inhibitors, 30 to 60 milligram. It has to be consumed 1 to 3 hours before sex. The ILT fold increase is 2.5 to 3. It is very effective in primary as well as acquired. Paroxetine, 10 to 40 milligram, 3 to 4 hours before sex. But unfortunately, though it is mentioned that it is going to really increase ILT fold to 11.6 times, there is a possibility of becoming dependent to this particular drug, or developing serotonergic syndrome, or if you really cross the level of 20 milligram or 40 milligram on a continuous basis, there is a possibility of manic shift in euthymic or the vulnerable hypomanic individual, or it is going to produce a delirious mania and already, may having manic problem. Third is fluoxetine SSRI 20 to 40 milligram, useful in acquired one, but therapy, I think the therapeutic effect would be perceived 2 to 3 weeks later. Sertraline, again, it is good, 50 to 200 milligram, 5-fold increase, but unfortunately, I think this cannot be taken as on-demand drug. Either at the time, just before 1 hour or 2 hours before the sex, the drug may be taken, or not on other days. But with reference to these SSRIs, especially sertraline, it has to be continuously taken. Unfortunately, this is going to produce unwanted side effects of sertraline, and there is a possibility of manic shift, and probably it may hinder the sperm motility also. Clomipramine, yes, 12.5 to 50 milligrams, six-fold increase. But again, one has to be a little careful with this drug. And there is a possibility, there should be opinion from the physician, and arrhythmic issues are also there. Tramadol, yes, good, 25 to 50 milligram, 4.74 to 7.3 fold increase. But unfortunately, there is a possibility of opioid addiction. And it cannot be combined with SSRIs. And this particular molecule, I think it will have multiple interactions. So in very specialized cases or refractory cases, or cases that are not really responding to other medical drugs, SSRI, that may be probably administered. Coming to PDI5 inhibitors, sildenafil citrate, sometimes premature ejaculation may be part and parcel of erectile dysfunction, that is ejaculatio antepartus. Even before intromission, the person is going to have ejaculation. Whether he's going to have partial erection or full erection, that's a different issue. But unfortunately, I think this is good when combined with other SSRIs. Of late, prilocaine and lignocaine and topical anesthetics and aerosol sprays are used, and probably they produce 4 to 6 fold increase. But what exactly is happening? It paves way for erectile dysfunction because of the loss of sensation over the penis and the partner's vagina, and not only that, skin irritation. So it advised condom use. But unfortunately, for a normal individual having normal erection who is able to penetrate appropriately and adequately, condom is fantastic, and absolutely there is no qualm at all. Imagine a person with a partially erected phallus and is trying to really, find very, very difficult to really, penetrate. And out of probably, undue expectation, is applying more topical anesthetics. Unfortunately, he is applying probably under the cover of the condom, and the erection is not there. And this is probably going to cause a lot of problems. Ultimately, there are certain individuals who used to get arousal, who used to get erection only at the time of probably making a contact with the clitoris or the vaginal orifice. Some people, for such people, I don't think it's not nice to really advise condom. Maybe it's used with SSRIs. Topical anesthetics, probably it should be applied very minimum. And condom, I think that should be really explained. And if necessary, some people they say that, why should I wear condom? Unless until I have a tactile perception, I don't think I'll have the erection. There are statements like that. So this has to be viewed with probably a little bit suspicion, and you have to really counsel the patient to apply very minimum spray of lignocaine. What are the non-pharmacological management of PME? Stop-start technique. The aim is to increase the frequency of sexual contact, increase the sensory threshold of the penis. And coming to sensate focus, the problem is not with the male. The problem should be construed as a shared problem, and both of them should be addressed by the therapist to alleviate the misconception. They should not have any kind of anxiety. If they have anxiety, they should be taught progressive muscular relaxation. Here, the individual is probably relaxing the muscle part by part. And at the time of total relaxation from head to foot, I think they may be in a position to perceive the impact of total body relaxation on the emotional tension as well as the psychic anxiety. And they should be emphasized to that sex is a normal, natural process, and it's a form of communication. And first phase of sensate focus, one, both the partners, I think they should be in a nude way. And one person should assume the active role, another person should assume the passive role, and the active person should touch the individual from head to foot except the genital area. Genital area is not allowed. While touching, the passive individual, if he's really getting some arousal, if he's really getting extra pleasure on touching certain areas, that should be noted, that should be understood, that should be communicated either verbally or non-verbally, and this should be used in the future foreplay of subsequent sexual experience. At any point of time, the male is really getting erection or going for ejaculatory inevitability. Even this touch is prevented, and the wife is probably resorting to skews technique, which I'll be explaining a little later. Second phase, here, in the first phase itself, I think the passive person, after some time, he is assuming the active role and he is repeating the same thing. So the erectogenic zones, the zones where if they are touched, if it produces maximum pleasure, that is identified, and that should be used in the subsequent foreplays. Coming to the second phase of sensate focus, I think both the people, I think they mutually stimulate the genital organs, and here the intention is to produce erection. And at one point of time, the person is really perceiving the ejaculatory inevitability that should be communicated to the wife, and the wife is not really doing anything. She's withdrawing, she's detaching, and the individual is allowed to go for detumescence. Then subsequently is stimulated, subsequently is allowed to achieve erection, and subsequently is allowed to go for detumescence. This is repeated 4 or 5 times until the person is extremely confident that he is able to get erection, is able to maintain erection, and that erection may be sufficient for penetration to the extent of producing orgasm in the partner. If at all, at any point of time, either in the first phase or in the second phase, if the individual is having ejaculatory inevitability, that should be communicated, and wife is immediately resorting to the skews technique. Skews technique is nothing but placing the thumb over the frenulum of the penis and the index finger and the middle finger over the coronal ridge of the dorsal side of the penis, and the firm pressure is applied for 1 to 3 minutes. And the individual is slowly, gradually going for detumescence. Then subsequently is stimulated, is allowed to achieve erection, and subsequently it is probably allowed to go for detumescence. This is probably repeated 4 or 5 times. Here, I think the cooperation from the wife is extremely important. This is a modified version of sensate focus. I'm not going to waste here because of the time factor. And once they are very confident that he can maintain the erection, this is a normal, conventional missionary position. But especially, I think, for the person who is really having premature ejaculation, the woman on top, that is the best position. There is an advantage in the woman on top because he is going to be passive, and that is going to reduce little anxiety. And the woman is in the driver's seat, and probably he is going to control. And if the erection is not adequate, partial, I think she's going to stimulate, she's going to tease the phallus, and that is going to produce erection. At the same time, if he is going to go, if at all is going for any kind of ejaculatory inevitability, she can try the skews technique. So she can really manipulate, and she can even, the woman on top can really modulate the movements so that I think the husband is able to, husband or partner is able to maintain erection, and probably that is producing some satisfaction, that is instilling confidence in a conscious as well as unconscious way. Maybe after overcoming the problem, we can really go for other postures. The teasing technique, nothing but stimulating the vagina or phallus or penis, and making the person to get erection and allowing the person to go for detumescence, again re-stimulated. The technique enhances the pleasure and confidence for both the partners, that they are able to really maintain erection for a stipulated period. There is another procedure called quiet vagina. Here, female partner is in the conventional missionary position. She is not exhibiting any kind of a movement, so that is not producing any undue anxiety in the male, and so he is able to perform without the anxiety. Another procedure is masturbating before intercourse. This is ideal for a younger individual who's got a short refractory period, not for a person above 50 years who's got longer refractory period, or the person who is on 5-phosphatase diesterase inhibitors like sildenafil to treat ED. Right. If you come across premature ejaculation, try to get the history, try to get that knowledge and awareness, and try to establish rapport, and psychosocial history should be obtained. Conduct a complete physical examination. Look whether it is PE likely or unlikely. If it is unlikely, it could be subjective PE or variable PE. Treatment is reassurance, education, psychotherapy, behavioral therapy, and follow-up. If it is due to, say, organic cause, manage the organic problem. If it is acquired, treatment is behavior psychotherapy first, SSRI combination therapy, follow-up, graduated withdrawal after 6 to 8 weeks. If it is a primary or lifelong, treatment is first line SSRI, second behavior therapy combination, follow-up, graduated withdrawal drugs, I think 6 to 8 weeks, lifelong treatment. And legal issues. See, we talk about premature ejaculation. I think we talk about impotence, erectile dysfunction. Whatever it is in the legal milieu, it is considered as an impotence. We talk about erectile dysfunction, but in the legal angle, impotence means, especially with I'm talking about the male impotence, failure to achieve erection, failure to maintain erection, failure to have insufficient erection for penetration, failure to really penetrate with the appropriate erection, and failure to produce orgasm. In spite of fulfilling all these criteria, the female says, Kuch nahi, I have not really enjoyed. The quality is not there. It should be considered as impotence. I have been attending courts, probably as an expert witness for impotence case for 5 or 6 cases in Madras, Chennai High Court. Organic impotence, I think that can be, if the female is lying, that can be really understood. There is something called vaginal plethysmograph, which could be placed in situ, and that would really measure the volume and pulsatile volume and the blood flow in the vagina, and that definitely throws some light whether the female is aroused or female is really going for orgasm or achieved orgasm. But psychological impotence, that cannot be proved in the court of law. The female says, no, I have not really enjoyed the quality wise, it is not okay for me. That cannot be proved, and the couples were asked to go on mutual consent. There are provisions. Hindu Marriage Act 1955, Section 12(1), Class A, Special Marriage Act, yes, there is a provision. Similar provision is in Indian Divorce Act, Parsi or Muslim Marriage Act. It should be incurable. It should not be acquired one, and it should be present at the time of marriage. It should be continuous to get a divorce. And at the time of filing the suit, the person should have that problem. So I repeat, premature ejaculation, that's based on ILT. If ILT is less than 1 minute, it is primary. It is between 1 and 3, it is acquired. If it is a normal ILT, it may be subjective PE or variable PE. Lifelong PME, they have probably like a genetic basis, neurobiological basis. And the treatment, there is a controversy or a conflict whether to administer on-demand drug or continuous medication, especially SSRI. As a psychiatrist, I would say better to go for on-demand because of avoiding unnecessary side effects of SSRIs and developing serotonergic syndrome or developing manic switch. Maybe combination therapy, better to avoid tramadol unless until in specialized cases or refractory cases. And this is definitely the acquired one. Even the subjective or variable one are treatable, curable, and pharmacotherapy with sex education, with psychotherapy, with behavioral techniques, one can certainly produce some quality in their experience. Thank you very much. I am here for your queries.